Great. Well, look, hello everyone. I can't see you, so it feels very weird talking to myself in the mirror, as I'm sure all of you are used to with these many, many days of Zoom and whatever this one is called, Google Meet and God knows what else, video conferencing. So my name is Rachel Sain. I'm speaking to you today from the lands of the Eora Nation, and I pay my respects to the Gadigal and Bidjigal people of this amazing place I'm lucky enough to call home. My name's Rachel Sain. I'm a strategy consultant. I specialise in co-design, which is helpful that my last name is Sain, which apparently in French means of health. So maybe I was born into this, who knows. In the past, I was a senior executive in government in various private sector organisations, and really today I wanted to share with you some of my experiences and insights in trying to increase the awareness, the acceptance, and importantly, the adoption of design in regards to digital health as a critical priority for the C-suite. So I'll now start sharing my screen. Feel free to drop some questions in as we go. I've got 3 screens operating, so wish me luck in getting them all working alongside each other. Right, here we go. Okay, so as I said, it's really all about trying to give you some insights from my lessons and how we can get the C-suite of health organisations understanding the importance of design as a critical tool in helping them achieve success in the transformation of healthcare. But first, though, I wanted to talk about digital health. You know, not long ago, it was health IT, it was e-health, and now all the rage seems to be digital health. And I like this definition best by the FDA, because what it does is it talks about the why. You know, it's not just tech for tech's sake. It's actually that we should be doing this to reduce inefficiencies, reduce costs, that type of thing. But for me, really, and this is a great diagram from a wonderful group called And Health here in Australia. For me, really, I think what it is just health evolved. And if we look at this image, we see the various care pathways or journeys and how digital technology is really an enhancement. I will still need a blood test. I hate needles, so I hate that that still has to happen. But I will benefit from devices that can scan my veins to assist the nurse when inserting the needle. My care team will benefit from the information being in a standardized format that's easily searchable and shareable. They might use AI and precision medicine and personalised care packages to tailor treatments through a telehealth consultation that I can undertake from home to discuss my results. And all of those things require design and user experience design in particular throughout the entire journey of that. But, you know, it's an evolving ecosystem. Some might say we're in the, forming and storming stage. We have our traditional life sciences group here, who, life science, biotech, medtech, who come from a world where it will take 10, 20 years for a product to get to market, although the vaccine for COVID seems to be much faster. But there's very clear IP around that and very clear sort of rules and pathways. We then move to our sort of e-health, health informatics kind of school of thinking. And some might say they're the old boys of digital health. They feel a bit of a sense of ownership of this space as the primary drivers of what's got us to where we are today, I would say. And then, the new boys, consumer tech, mobile health app. Loads of non-health companies are entering this space, from Google and Amazon to mid-tier small businesses, local startups. All of these people have a very important role to play, but they have a different lens and different experience and different language about what digital health means to them, what's important and what's of value and worth investing in. So I would say design is another term that different people have different views on. If I was to ask a group of 8-year-olds, what is design? What do you think a designer does? Well, what might they say? They're likely, unless their parents work in the space, to say, well, they draw stuff, they make things pretty. It's that top of the iceberg, very much about, what you see, what you touch. And in my experience, not saying that executives are 8-year-olds, but in most health orgs, whether it's gov or private, it's not too dissimilar. And it's really not their fault, because if I was to put you in a room of lawyers or software engineers, clinicians, whatever flavor or skill or industry you want to talk about, we might be equally as blinded in terms of our view of what it is they really do. And often when people think about design, it is that area on the top there, what you see, what you touch. But as I'm sure many of us who are designers will know, it's really about, it's a process that solves problems. It's the how. Now, how you do that and creating meaningful outcomes can be in very many different shapes and sizes, and simply could be something that tells a great story or is beautiful. That can, of course, be very meaningful as well. It doesn't have to be that huge strategy there. I'd love to get a sense of who's on this call. Could you pop into the chat whether you identify as a designer, a clinician, a consultant, or any other flavor there, so I can see who's in the room? I feel like there should be some jazz hands and music going on while I do this. Designers. Oh, nice. Very good. Okay. Nice. So lots of designers and lots of big D designers, people who really understand this iceberg, I imagine. So that's awesome. That's really good. Future doctor. Woohoo. Well done you. Good luck with that. So some of you may, I imagine, know Audrey Crane. She wrote a book, which I have to say I haven't actually read yet, but I want to. But I did read her article on Medium about the book she wrote is called What CEOs Need to Know About Design. And look, it's not specifically health focused, but I found myself nodding along furiously as she talks about the reality of life trying to get design to be acknowledged as a priority and skill within the executive area. So this brings me to my own example. And look, there's sadly a lot to choose from here, but I'm going to give you a relatively recent one, but I have sort of merged a couple of stories to protect the names of people who might be identified. So I was working somewhere that had a major transformation project going on. Part of this was co-designing a new registration process, and the head of comms, a senior exec, he sat on board meetings and with me on the exec, wanted to see what the output material might look like, what the walkthroughs. So our design team developed this, we sent it over. Late that afternoon, I got this really panicked call saying, Rach, I think there's a problem with my computer. I said, oh, all right, well, I'm not the IT department, but how can I help? What's going on? And he said, well, that file you sent has been corrupted. Okay, these things happen. I'll take some screenshots, put it into PowerPoint and send it to you. No problem. Again, another call, very worried. Rach, it's got this really weird text on it. Now, it took me a moment to realize that was lorem ipsum. Now, as I can see, most of us are designers. This is our language. We understand that. And I do not say this to make fun of him or to call him out, because he is a very smart man, but he came from a government policy comms background and had little exposure to digital at that time. And talking of digital, I was the one who was not understanding the language at one point. About 6 years ago, when we were still sort of saying e-health, I was presenting to a bunch of senior execs in a health org, clinicians mainly. I was working with and couldn't help but wonder why a few of them kept sort of smirking and trying hard not to laugh, because I talked about the needs for a solid back-end infrastructure to support digital health. Well, any clinicians might be giggling here. Digital in health is what you see on that screen there, a finger. So you can perhaps understand why there were a few laughs when I was talking about that. But both of these events really make me think that we need to remember not everyone speaks our language. That's the first and most important message I would say to you when you're trying to win the hearts and minds of the executive, of that C-suite, to support and fund the design work that is so essential that you do. Who are you talking to? What's their language? How do they view the world? What are the key phrases or language that works for them, the trigger words? And often, in fact, we are, talking the same language, tomato, tomato, just using different words. So a large part of being a designer, I think, in health is about translating information into the right context. You'll see on the page here that the terms patient-centric care, person-centered care, user-centric models, even the increasing use of participatory medicine, co-design and user-centered design, they often share the same common principles. And I would strongly suggest, if you're speaking to a chief medical information officer or chief clinical officer, that you find a way to bridge that gap and highlight the synergies of the words that are common to us and the words that are common to them, particularly in the role of clinical governance, safety and quality measures, and how design and user experience design plays a role in that. So what's keeping executives up at night? Pardon my French. Yes, tomato might actually be because of my Kiwi accent you can hear underneath there. So I would say, pardon my language, that 2020 has been a bit of a shitstorm, really. The disruption brought about by the bushfires earlier this year in Australia, then, of course, COVID, the pandemic. In terms of, trade, supply chains, inability to travel, plus I'd say rising skepticism and lack of trust in some sectors, particularly towards corporate brands. Many staff are also now saying, wow, I don't have to spend 3 hours on a train. Maybe we could move to a more permanent work-life balance. So all of these things are disrupting. I'm also extremely pleased to see The Economist reporting that climate change is now firmly on the executive agenda, alongside dealing with political instability and economic downturn. And really that economic downturn is going to be a big one for the next 3 to 5 years. And that's a big pile of stuff to deal with, particularly with limited budgets. And sometimes that means the nice to have stuff, like what many of those people think design is, becomes deprioritized. We'll just do one round of user engagement. Someone who's got heart disease, one patient, just ask them, that'll be fine. Now, all of us, I hope, have got a horrified gasp saying, no, we must ensure that doesn't happen. So while those issues I spoke about are kind of there for everyone, there are some additional healthcare specific ones. New research from Huron shows that in a matter of months, the coronavirus pandemic has materially shifted the priorities of leaders, and it's accelerated investments in some areas which are focused primarily on financial stability, pandemic management, and changes to care delivery. That makes sense, funding of PPE, revised workflows, that type of thing. But the challenges of COVID are changing how health organisations operate, as well as the consumer expectation and preference for care, particularly around virtual delivery models. Short-term adjustments have been necessary for orgs to continue to deliver care safely while stabilising that financial impact that this has created. But at the same time, leaders are saying they're not abandoning their long-term strategic plans for transformation, be it of care, cost, technology, or overall rethinking of how healthcare is delivered. I want you to think about that phrase, rethinking how healthcare is delivered. Now keep that in the back of your mind. The research goes on to say that 6% of the execs' short-term plans and 77% of the long-term plans will remain mostly unchanged. However, what will change is a reprioritization of certain elements of that strategy. Keep that in mind as well. And finally, the research says due to crisis mitigation from COVID, the need to stabilize financially, leaders are reverting to old ways of thinking when it comes to return on investment. So what have we got there? Continued focus on how healthcare is done, long-term change, but certain elements will need to be reprioritized in some way, safe way, reverting to old practice, which means being led by that word that went through all of that, which was money, finance. So a similar survey in 2019 from Sage stated that 69% of execs said improving the healthcare consumer experience is their organisation's first or second top strategic priority. Hooray! They're finally getting it. It's great. But only 32% have a dedicated C-suite exec who's responsible for this type of thinking. Now, this all sounds pretty heavy, big economic, awful stuff. And you can kind of get a sense of how on earth do I actually to shift the dial and face this uphill back, getting design a seat at the table and an acknowledgement of its importance. Well, here comes cheesy meme time. I strongly believe that it's about framing. It's about seeing the problems being faced by the industry and by you as a designer seeking to get more traction for your ideas and ways to solve them. That if you reframe them, they really are opportunities for you to increase the role and how design can help organizations tackle those challenges. So let's pick some of those big challenge areas, get into them a little more. I think so creating this perfect storms of challenges that are really holding back our ability to achieve true transformation within health, or perhaps they're just opportunities to do things differently. So first and foremost, this graph here shows us healthcare is getting more expensive. As a percent of GDP, we're now up well over 10. This is back from 2013, so it's actually quite old. I should have updated that. But what you'll see the trend, so this purple area here is patients. The patients' share of the bill of healthcare in Australia is growing enormously. Now, on one hand, you could say that that's an opportunity because consumers are more willing to contribute and pay for health services. So some of the challenges of bringing direct-to-consumer products to market may be being mitigated, one way to look at it. The other thing is that we're seeing the pace of change is increasing exponentially. Every day there's a new app, a device, a service, a thing that I have to read about and know about. This graph here sort of shows how long it took to achieve certain adoption rates for different types of technology. Anyone who was involved in Pokemon Go, I think that got something like, I can't remember the numbers, but multiple millions within a matter of 10 days. And this is really starting to create a strain. It's increasing the challenge of gaining and retaining people's attention and engagement, not just of what we typically think of as patients, but also with providers, with anyone at all, any human is being affected by this. The study that was done in 2017 says scientists now believe, on average, we have a shorter attention span than a goldfish. So I'm wondering, 17 minutes in, are you all still with me? Are we listening, or have you buggered off to look at your emails? Fair enough. Another challenge that we see is that physicians are telling us they're burnt out. This new technology, the use of EHRs, all sorts are contributing. This pie chart was a survey from senior nursing staff. It showed that 30% of their time spent on hospital and patient admin is usually through multiple systems that are not interoperable, often require different passwords, and require ongoing training and support, all increasing operational overheads for health orgs. And there's also this idea, I would say, of digital transformation fatigue. They've seen a lot of programs come and go, oh, this is going to revolutionize everything. We'll just a computer to do it, and sometimes it doesn't actually win, often because they didn't include design. So on top of the battle for our attention, this new way we live is contributing to a shift in the burden of disease. So this figure here was from, I think, 18 something, and a lot of it, as you would imagine, is accidents and issues there, versus 2018, the burden of disease is much more on lifestyle-based issues. And we know, that our mortality and morbidity, so our length of life and quality of life, is 20% due to clinical care, even though clinical care receives probably about 95% of the funding, 30% down to our behaviours, and 40% to social and economic factors. And often these kind of lead to these. When you think of, what's an example, affordability and accessibility of fresh food can mean lower socioeconomic groups eat poorly and in turn increase risk of disease. We also see an increased use of social media, a health behaviour, leading to increased issues with mental health, particularly for young people. There's also a lot of regulatory transformation going on. Many countries are looking to try new models of care from a sort of fee for service to fee. I'm sure many of you will already know this, but when you go to the GP in Australia, they just get I think it's $37.50 from Medicare per consult. No, it doesn't matter whether you did what the doctor said, doesn't matter if you got better, it's just fee for service. Fee for outcome model is based more around, how are you driving a positive impact for the patient. So some of you will be familiar possibly with Porter, if you do any change management work. He describes the value chain as a collection of processes that a company performs that creates value for its consumers. Well, as you can see by this pretty challenging landscape map, the value chain in health is pretty tricky. In health, the way things are funded, so where the money comes in, structured and actioned, can often lead to some perverse challenges. So if you do something in one part of the system, the value might come out at a different part, and that can mean driving change can be really tricky. Again, big, complex, gritty challenges. Well, big D design, the whole full iceberg, is really about how we do things. And as such, I really think we've got an opportunity as a design community to, more so than ever, increase the importance of design as a tool for helping solve some of these challenges. Okay, great. How? Well, firstly, I'd say there's a really big cultural hurdle we have to get over. Sites like Fiverr, Freelancer, various designers, and I'd include UX designers, who in my view, as I said, should be involved in every step of the design, as the experience really kind of starts, even before the motivation. I get very frustrated when I see journey maps that start from the patient sits in front of the GP. I said, yeah, but why? It actually starts when I woke up that morning, opened the bathroom cabinet and saw, oh, I haven't got enough pills. Then comes the journey. Anyway, and I think it doesn't really help when someone says, oh yeah, I got this logo or website done for $100. So first and foremost, we have to value ourselves and our craft. And part of our craft is understanding users. We're really good at it. We understand behavioral science. We are, in a way, best placed to understand how to use these tools to drive adoption and engagement at the C-suite. Not just, engagement and adoption and a better experience of the products and services we design. So behavioral science, behavioral economics is being used to help nudge behaviors of citizens and patients, but it can be a great way to understand how to influence and drive awareness and support for new ways of thinking with your own organization too. On a micro level, there's often a culture within the C-suite, quite a closed culture that may not even be sort of easy to see from those outside it. There's a social system, there's a hierarchy. Every different executive group that I've been part of has its own flavor, its own kind of tribal patterns, and their own language. That word language is there. So using these tools can help you to position the importance of the work that you do in a way that will be more likely to be taken seriously. I gave a talk at HIMSS last year about behavioural change and its impact on health. Very happy to send you a link to that later if anyone's interested. But I suppose the big thing is what's of value to the C-suite, and a big part of it is money. So this was something I did many years ago, I think about 8 years ago now, presenting this to a group of execs on a project I worked on. We were able to actually start to have a real dialogue about the importance of, and this was interface design, but design in the whole role of a new patient management system. So I've talked a lot about the language. It's also about understanding the process of or context of how change works. And here's an example. I used to work in the entertainment industry in telly a long time ago, and a lot of friends still work there. And this is a snap I took from Facebook. A friend in the arts was flabbergasted. How come people are allowed to sit on airlines, but on planes, but they're not allowed to go into a cinema or a concert or anything like that? Now, there's a whole subculture of conservative views of STEM versus STEAM, and I wish people would put the A of arts into STEM. And, the fact that airlines are often massive companies propped up by government, seen as too big to fail versus, lots of little arts companies. And importantly, airlines understood at the beginning of this crisis not only the language of driving change and adoption, but the process and mechanisms for it. So they very quickly funded research that was published to support the changes that they were after. Now, why am I sharing this? Because you need to not just understand the language and the culture of your C-suite, you need to understand what makes them change, what drives change in their world. And often in government, it's evidence, it's published academic literature. So observe and understand your users, their views. Healthcare, like other industries, is facing very hard challenges, and the health-specific ones are pretty complex. So there is that growing awareness. Co-design is now kind of a common term. Design thinking is there, although I'm not sure they really understand what it actually is, but it's another topic. But observe and understand your users, your executive, their views. Become a speaker of many languages in that sense. And how does change happen? Is it based on who said what? Are you in a fear-driven organisation that's heavily focused on regs? Whatever your language, your context and processes, understand those. Be a researcher, a user researcher, experienced researcher, and utilise those skills you have to showcase how design really does deserve a seat at the exec table, and it's a winning strategy for solving these complex problems. And look, one final point before I finish and see if there's any questions. Try and think about the outcome of your work in the mindset of the quadruple aim. Now, can I get a little yes or no on the chat there? How many of you know what the quadruple aim is in health? No? That's okay. All right, no worries. So the quadruple, well, it started as the triple aim in the 1980s. And what it was because a lot of health was funded by government, they said, well, when we invest in health, it should lead to these three outcomes. The first one, it should make the individual better. No brainer there. The second one, ideally, it should improve the whole population's health. And the third one was around the economy. It should reduce the cost of care. So every initiative we do should achieve the triple aim. Now, about probably 10 years ago, there was a lot of research that came out around workforce burnout, clinician burnout, and said we need to make it a quadruple aim and ensure that those initiatives improve provider well-being. So that's the quadruple aim, if you ever hear anyone talking about that. I myself am aiming to try and get to this sixth leaf because I also think investments should support industry, including design, UX. We have spent in Australia, $2 billion already just on the My Health Record infrastructure. Many of that has gone overseas to large, big corporations rather than smaller groups. So it'd be great if that investment in the transformation of health could go to, local enterprises and people like who's on this call. And really importantly for me, I absolutely think we have thinking about and saying that the investment in health should be reducing the environmental impact. In Australia, 7% of our greenhouse gas emissions come from the health sector. And obviously we're the first group that has to deal with sick people from from climate change, whether it's air pollution from bushfires or storms or any of that type of thing. So where possible, I'd love to see, design playing a role in helping achieve this. Okay, so I'm going to stop there. I think I've got a few minutes if there's any questions, and I'll put on the screen here my details, Sain on Twitter, or that's my direct email there. But fire ahead with any questions you have.
Rachel, thank you so much for that. I don't know if you can hear me.
Yep, I can. Perfect.
Thank you so much for that. Really insightful talk there. Look, I think the thing you mentioned mostly is that, as a UX practitioner, is having the seat at the table. If your department is seen as a culling department. So, how do you break down their barriers? Is it over time? I think in every event I've been in, a lot of the practitioners say the same thing, is that stakeholders don't really see the value in what a practitioner brings. And that's the biggest battle and concern. So, I mean, do you have anything to add to that?
Well, again, as I guess the summary points there of think about the language of how you're trying to position something. So even just when you're talking about, like if you can frame what you're trying to do along the clinical governance, safety and quality framework, this is how it contributes. They start to find hooks in the language and the vocabulary that they have. Oh, hang on, I understand what that means. So the language, the context, typical just change and adoption activities of trying to find who the decision makers are in your organization and increasing awareness and importance of that. Even, simple things like asking to do a lunchbox session where in an organization where you can talk about the role of design, and you can do a presentation to your staff or to the org about what's happening, and include so if, for example, your CEO did an MBA at Harvard or did an something like that, include some references of the Harvard Business Review talking about what you're saying. So find ways to position it so it's not just, and no offense intended by this comment, some CEOs think of very highly paid head of design as just a graphic designer. So if you're saying it, they may go, yeah, whatever. But if you're saying it and it's backed up by people that they believe in and support, you'll be able to shift the dial a bit more.
Makes sense. Okay, thank you for that. Is there any other questions though? Well, we do have about 4 minutes. And thanks again, Rachel.
No problem at all. And good luck to all of you with your design work. We absolutely need it to help make healthcare better. Your role is really, really important. So stick with it.
Yeah, brilliant. Thank you.
Thanks. Bye-bye.